Today, we're diving deep into a critical medical protocol, the one for perioperative prophylaxis when a patient gets a cardiac implantable electronic device, or a CIED. You can think of these devices as these tiny, life-sustaining maestros for the heart. But implanting them comes with a very real risk of infection. So let's break down how we manage that risk.
First, we'll talk about why prophylaxis is so non-negotiable. Then, we'll identify the key microbial troublemakers we're up against. After that, we'll get into the details of the first-line defense protocol and how we handle clinical complexities. We'll also touch on the core philosophy of prevention, and finally, we'll put it all together with a few case studies.
So let's start with the stakes. Why is this protocol so incredibly important? Well, it's pretty simple, really. Putting in a CIED, even though it's a life-saving procedure, means breaching the body's natural defenses. And that creates a perfect opportunity for microbes to get in, leading to a device pocket infection, which frankly can have absolutely devastating consequences for the patient. And that inherent risk is the whole problem we're trying to solve. You see, a CIED infection isn't a minor setback. We're talking prolonged hospital stays, systemic infection, sepsis, and even the need to completely remove the device. So prophylaxis isn't just a nice-to-have, it's an essential strategy. It's about building a microbial fortress to protect both the patient and their new life-saving device. Okay, so if you're going to build a fortress, you need to know who you're fighting. This brings us to our microbial adversaries, the specific bugs this protocol is designed to take out. The main targets are the usual suspects in surgical site infections for these procedures. Prophylaxis is aimed squarely at Staphylococcus aureus, which is the #1 offender, usually coming from the patient's own skin. We also target some gram-negative bacteria like Enterobacteriales. The whole point is to prevent that dreaded device pocket infection. There is an analogy here that just nails it. It really does feel like trying to hurt cats. You can't possibly target every single pathogen out there. But what you can do, and what you must do, is have a solid plan for the most likely troublemakers. And in this world, Staphylococcus aureus is definitely the top cat.
So, we've identified the enemy. Now let's look at our weapon of choice. This is our first-line defense, the Cefazolin standard.
The standard protocol is all about precision. Cefazolin is the go-to because it works really well against the bacteria on our skin, especially Staphylococcus. It's given intravenously, but listen to this. The timing is everything. It has to be given 15 to 60 minutes before the surgeon makes the first cut. That ensures the antibiotic is already in the tissue, ready to fight the second the procedure begins. For a standard adult in a straightforward case, a single 1-gram dose does the trick. But, of course, there are always exceptions. The protocol is smart about this. Cefazolin's half-life is about 2 hours, which means for a really long surgery, we're talking more than 4 hours, you need another dose to keep those protective levels up. Same thing goes for significant blood loss, say over 1.5 liters. That can dilute the antibiotic, so you need another dose to maintain that antimicrobial shield. Medicine is definitely not a one-size-fits-all field, right? A good protocol has to be flexible. So now we're going to look at how the standard approach gets tweaked for patients with specific issues, like allergies or other known risks. The first big fork in the road is an allergy. Cefazolin is our standard, but if a patient has a confirmed serious beta-lactam allergy, you have to pivot. The protocol calls for a switch to something else with good coverage against those gram-positive bugs, usually Clindamycin or Vancomycin. It's all about keeping the patient safe without sacrificing effectiveness. Now, for another layer of complexity, what about a patient's own bacteria? We know that people who are nasal carriers of S. aureus are at a much higher risk for a surgical site infection. So for these patients, the protocol adds another step, a decolonization treatment with Muprosin nasal ointment. The goal is simple: reduce the amount of bacteria at the source, and you reduce the risk of the patient infecting themselves. This is such a powerful way to think about it. By screening for and treating these S. aureus carriers, we're basically neutralizing a major risk factor before it even has a chance to become a problem. It really is like disarming a bomb before the timer even starts. And that whole proactive approach, it really gets to the core philosophy that drives this entire protocol. It's a simple idea, but it's absolutely central to keeping patients safe. Here's the key difference.
Perioperative prophylaxis is not about treating an infection that's already started. It's about making sure an infection never gets a foothold in the first place. Every single step, the choice of drug, the timing, the dosing, it's all designed with one goal in mind: prevention.
And if you take away just one thing today, please let it be this. This statement captures the soul of prophylaxis. All of that planning, all of that precision, it serves one purpose. It is the foresight that saves us from the tragedy of having to apply hindsight.
All right, so we've covered the theory. Now let's get practical. We're going to walk through a few short case studies to see how all these principles play out in the real world.
Okay, case number 1. Let's start with a foundational scenario. A patient is coming in for a standard pacemaker implant. No known allergies, no special risk factors. What's the antibiotic and what's the all-important timing for giving it?
The correct move here is Cefazolin, given intravenously inside that critical window of 15 to 60 minutes before the incision. That timing is what guarantees the antibiotic is at its peak power in the tissues right when the risk begins.
All right, let's make it a little more interesting. Case number 2. This patient has a confirmed beta-lactam allergy, and pre-op screening shows they're a nasal carrier for S. aureus. What 2 key adjustments does the protocol call for? This case really shows the protocol's adaptability. First, because of the allergy, you switch the antibiotic to an alternative like Clindamycin or Vancomycin. And second, you add the mupirocin nasal ointment to decolonize the patient and tackle that extra risk from them being a carrier.
And for our last case, let's tackle a question that comes up all the time. A patient is scheduled for a device exchange, just replacing the generator, not a whole new implant. Does that change our prophylactic strategy?
And the answer is no. The protocol stays pretty much the same. Look, whether you're putting in a brand new device or just swapping out the generator, you're still creating or reopening that device pocket. The fundamental risk of introducing skin bacteria is identical. So the principles, the timing, and the targets of prophylaxis all hold steady.
And that brings us to our final thought. In a world of these amazing, life-saving technologies, it's this careful, deliberate act of prevention that makes it all possible. It isn't just a goal, it's a clinical necessity. It's the unseen, proactive work that allows those tiny maestros of the heart to do their jobs safely. Thank you for tuning in.